Dr. Whitaker, you are live, and we are ready to start the meeting.
Oh, thank you so much, Kim. So I'd like to call the meeting to order. It's August 7th, 10:05. We are meeting via Zoom for our statewide Medicaid Advisory Committee meeting. I want to confirm the roll call of members. So it might be easier if I just call out your name and you just signify by saying present. Alejandro Clavier.
Present.
Andrea Daines.
Present.
Thomas Huggett.
Present.
Marvin Lindsay.
Present.
Ann Lundy.
Present.
Amber Smock.
Present.
Kai Tao.
Present.
Nellie Vasquez Rowland.
Present.
Samia Vora.
Yeah, present.
Thank you. Howard Peters.
Present.
Arnold Cantor. Arnold, if you are on, if you could raise your hand and we can admit you to the speaking platform. All right, thank you very much. And then the roll call of HFS staff. I know that Director Eagleson.
Whoops. Yes, good morning. Have to unmute myself.
Thank you. Medicaid Administrator Kelly Cunningham.
Present. Good morning.
Thank you. I know that Robert Mendonza is on.
That's present.
Thank you. Laura Phelan.
Yes, here. Thank you.
Jane Longo is with us. If
Yes.
there are other, is Dr. Goyle on? If there are other HFS team members, could you identify yourself, please?
I don't think I have to say anything, but Kim McCullough is on, Dr. Whitaker.
Oh, of course. Thank you, Kim. Okay. Anyone else from HFS on?
This is Amber. I just want to point out that the captioning seems to have stopped.
So we're going to take just a little pause here we could make sure the closed captioning is up. So guys, let's take a pause. Kim, you're going to look into that for us.
We're working on it, Dr. Whitaker.
Okay. So Amber's going to need it. You might want to just give us a sense of how long you're going to take. So we may just need to take a brief pause here.
Give me 2 minutes.
Okay. So guys, look, we need to take a brief pause where we get the closed captioning up. So just give us a second here, take a quick break. Thank you.
Dr. Whitaker,
Yes.
you can proceed. Just start speaking and the captioner will catch up.
Okay, thank you so much. And Amber, if you let us know, you can raise your hand to let us know that it's meeting the need. Okay, appreciate that. Thank everybody so much for coming together in this Zoom meeting. We have to start out by acknowledging that we're in the midst of really unprecedented times. In fact, a global pandemic of COVID-19, a novel coronavirus. But as we have we all been living that, all pandemics indeed are in fact local. And in our case, right here in Illinois, we are sort of managing through our sort of unique situation. The Illinois response has been supported in large and significant part by Healthcare and Family Services and the team. They've had to work and sort of put forth extraordinary efforts to respond to not only locally every single day what's going on, but to federal guidance, the various mandates that are coming down at warp speed, and really implement them at the local level with precision. So I want to first start out by thanking them. It's been quite challenging times for all of us working in the space, but particularly for those regulators who are having to manage the multiple inputs that are coming in while meeting the needs of the individual participants in the Medicaid program. Today we've got a full meeting, and we want to start out by taking a look at our minutes from the last meeting, after which we will, I believe the director is going to review the Medicaid Advisory Committee charter, just to remind us of here's the work that we're called to do. We'll then go to public comments. And then we'll have the Healthcare and Family Services Executive Report, where they'll go through a series of agenda items, including an update on the COVID-19 response and various federal waiver state plan amendments. We'll walk through enrollment, eligibility, and redetermination, review an update on telehealth, where we are with integrated health homes, and an update on long-term care facilities. We'll hear from the Medicaid Managed Care Program with some highlights, and then we'll walk through hear from subcommittees. You did receive, I believe, those committee reports by email, but we'll hear from those subcommittee chairs. We'll towards the end of the meeting then have a session for the committee to pose recommendations, to the director based on things that you've heard during the meeting or experienced in your day-to-day work. New business, old business, then adjournment. So any questions on the agenda before we
Dr.
proceed?
Whitaker, Dr.
Yes.
Whitaker, I'm sorry to interrupt you. I see Amber motioning and she held up a sign that it's not working. So I think we might need to pause again, I'm sorry to say, because we need to make this meeting accessible for everyone.
This is tech
100%.
support.
So we're
we're
going
still
to take a pause, and you could take a look into what's going on, and then come back to us and give us an estimate, and we'll accommodate whatever needs to happen here. So thank you so much for letting me know that.
Tech support was trying to say something.
Yeah, we're working on. There's some issue with the Zoom. Zoom is not bringing up the captions, so we're resetting the captions link. So just bear with us.
Okay, very
Working
good.
on it.
So we'll take a pause. You can stop your video if you like, and everyone will wait to hear about our return. Thank you so much for letting me know.
Is the caption stack now okay?
I don't see it. This is Kai. I'm looking at the screen right now. I'm not sure, Amber, if you can. I don't know. Does that go to YouTube only? When I turn on my closed caption, it goes custom live streaming service, and then it puts me to the YouTube for everybody else. Is that why? Let's see. I don't see anything.
To all of our committee members and to the public, I know that we did in fact test, we tested this. So we apologize, but technology, when it works. And then sometimes there's a quirk that you didn't anticipate. So we could just be patient here. And I think, what we'll have to perhaps, by 10:30 or so, if we can't get it to work, we may want to think about, rescheduling this meeting once we confirm that we've got that system up and running. So let's hold tight another 5 minutes and see where we land. And I do apologize to everyone.
Is the tech team on the meeting?
Yes, we're still working on it.
Still working on it. Okay.
This is Amber. I just want to point out that I have seen captions stall on Zoom platforms before, and what tended to clear it up was when the captioners logged out and then were admitted back in as panelists and just restarted that way. Hope that will be considered. Thanks.
Thanks, Amber. Did the tech, did you hear that? And have you tried that? Because I think in a couple of minutes, we're going to have to reschedule if that doesn't work.
I see closed caption on the bottom now.
Yes, they're working now.
Yeah, they're
All
working.
right. Amber, can you see? It is delayed.
Yes.
This is Amber. Yes, I do. I do see the captions are back on. So let's go ahead and carry on. And I realize that demanding access accountability in this way is a lot, but it is what it is. We do need to be accessible. Thank you.
Yeah, Amber, please don't apologize. It's absolutely the right thing to do, and we want to do it. I think we're just challenged with this new structure, right? So while we work through the kinks, I'm hoping that, in the future, we've got it down. So this is good. So let me know. Did you say we could proceed?
Yes.
Yes.
Okay. Great. Okay. All righty.
So
Well, I think
Dr.
we're going to
Whitaker-
move through the agenda actually, though, still pretty nicely. So we were, we went through the agenda. So we reviewed, so hopefully you have it in front of you. It was emailed to you, I believe, yesterday, if not 48 hours ahead. So you'll see the agenda. Amber, I want to be sure, when I went through the agenda, did you get that part? Do you have it in front of you? Amber, you have the agenda? Yes. Okay, good. And so if there's were there any other concerns about the agenda? Anything you guys want to add to new business? And I know it's tough meeting where I can't see all of you. I can only see 3 people. So I'm looking at Amber, Samir, and Jane right now. So if you have anything to say, just speak it out.
So Dr. Whitaker,
Yes.
to the agenda, if the chair would accept a motion, I would move to approve the minutes.
Yes. So the minutes from February 7, 2020, there's a motion to approve.
This is Ann Lundy. I second that motion.
Okay, motion and second to approve the minutes. Any questions about the minutes? Additions, deletions?
Nope.
Okay, all in favor?
Aye. Aye.
Aye.
Aye.
Or anyone opposed?
Aye.
Okay. Was there someone who opposed?
That's just the delay, I believe, in the caption.
Okay, sorry, guys, because I'm having a little bit of just internet instability here. So, okay, I think I heard the approval. So the motion minutes have been approved. Moving forward, we've got the director is just going to review the charge of the Medicaid Advisory Committee. Director Eagleson.
Thank you, Dr. Whitaker. Good morning, everyone. And welcome to our first virtual official MAC meeting. And like every MAC meeting and maybe every meeting these days, apologies for the technology, but we will get better at this as time goes on. So the Medicaid Advisory Committee is created to advise the Department of Healthcare and Family Services, which is designated as the single state Medicaid agency, to our federal partners. This group is created to advise us about really all aspects of healthcare and medical services under the Medicaid program. This is a requirement under federal regulation and with respect to policy and planning involved in how we run the program. So there is a set of bylaws that this committee reviewed last, I think, in the fall of 2019.
Yeah.
It lays out the membership, how often this group meets, all those kinds of things. But really, we had been making an effort when I was at the department previously and now again. We really want this body and all of its subcommittees that it has the ability to create to help us, advise us around policy development and program administration. So we are also working on a strategic planning process within the department. We're up to about 60 or so of our team. We keep growing, and sharing it with more and more staff. And we are now sharing the initial vision and things with a broader group of staff even. And we will bring that to this committee when that process is through in a few months, and share it with you and other stakeholders. But we just really wanted to, A, thank you for your participation in this group, and B, tell you how much value your input in a variety of ways is to us improving the program. So with that, I will turn it back to you, Chairman Whitaker.
Thank
Chairwoman.
you, Director Eagleson. And, to the committee, I asked the director to kind of help us reset and make sure that we're all clear on what our roles are here. And I appreciate all of you. I just want you to know the, various emails and reach outs about what you want on the agenda, what you want to hear about. And the director and the department, they've been extremely responsive, guys. So your work, your input is valued. And thank you for being here today. We're going to move to public comments. We want to hear from the public. Kim, I'm going to ask you to take over and manage that as we move forward. Let us know how many speakers we have, and you could manage that part. We appreciate it.
Are you able to hear me, Dr. Whitaker?
Yes, I can.
Great. Great. Good morning, everyone. We have 3 public speakers today. Each public speaker has 3 minutes to speak. We are going to ask that you please stick to that timeline in lieu of our time crunch at this time. We're going to start with Julia Mobarn. If you can unmute yourself, you have the ability to unmute yourself and to begin speaking, please.
Hi, can you hear me?
Yes.
Yes.
Yes, hi, my name is Julia Moberhan. I'm a pediatrician in Chicago who has taken care of Medicaid patients for 23 years. I ask everyone, how can it be fair and just for an MCO to recoup money for a previously paid healthcare claim after the provider verified in Medi that the member was covered on that date of service? Because of a change in eligibility that is retroactively applied, the MCOs recoup money from healthcare providers for patient visits going back years. The providers then suffer the unjust monetary loss. We have an equitable right to rely on what is stated in the Medi portal on the date of service and rely on the verification process and the representation of coverage. We are not financially responsible for a patient visit when there is a gap in coverage due to problems with redetermination. We are not the guarantors. The MCOs and HFS are. This unfair process must be fixed. I seek a fair solution for all Medicaid providers that have suffered the same monetary losses as my practice has. And thank you very much.
Thank you, Doctor.
Thank you, Doctor. Our next public speaker is Jenny Pinkwater. Jenny, if you would kindly unmute yourself.
Hi, this is Jenny. I don't have any comment at this moment.
Thank you so much. We appreciate your time. The next public speaker is Daniel Perez. Dr. Perez. Okay, we're going to move on. Dr. Whitaker, Dr. Perez is not on the line.
Okay, thank you very much. We're going to move to the Healthcare and Family Services Executive Report. I'm going to turn it over to Director Eagleson and her team.
Thank you, Dr. Whitaker. Good morning, everyone. As I said before, welcome to our first virtual version of the Medicaid Advisory Committee meeting. I'm so glad that so many of you are on the call today. Thank you for your patience. And I hope all of you and your families are doing well during these unprecedented times. My name is Teresa. I'm the director of the Department of Healthcare and Family Services. We do have a jam-packed agenda, so I will be brief and make just a few remarks. You'll be hearing from other key leaders at Team HFS today, including Kelly Cunningham, our Medicaid administrator, Deputy Directors Jane Longo and Kimberly McCullough-Starks, and many more. Let's start this morning with the best part of the job and something that I think is worth saying again and again. I really believe that HFS should really stand for helping families succeed. Even in this unprecedented global public health emergency, I am so proud of this team. And all that our dedicated personnel do every day for Medicaid members. I also want to say the same thing to you. Thank you. So many of you who are attending this morning from all around the state. There's really not been a playbook for all that we've been through together since March. There have been so many incredible examples of providers and advocates and managed care entities stepping up to make a Herculean effort to serve our 3 million Medicaid members in new and different ways, and ways that we hadn't even thought of several months ago. So the efforts by each of you and your teams is absolutely recognized and very much appreciated. So like so many of you, the team at HFS has been working around the clock to implement new and previously, unthought of services, flexibilities, authorities, policies, and procedures to serve our clients. We have submitted several requests for federal waivers and multiple state plan amendment requests. We've requested emergency authorities for our 1915C waiver populations. Those are alternatives to long-term care and other facility-based services. We've changed eligibility procedures. We've implemented emergency telehealth rules, which we just recently filed a second notice of to implement those rules permanently. We've issued numerous policy changes, billing guidance, and new codes. Through all of it, we've been trying our best to keep you all as informed as possible. In fact, a stat came to my attention the other day that I wanted to share with you all. Our team so far through July has drafted and published over 120 provider notices. Normally in a year, so we're halfway through the year, normally in a year we publish only about 100 of those documents. So for all the work we're doing, we also know that you're adapting to all of this. So we are trying to make it easier for you to find these changes. We have a red box on the main page of our website, www.hfs.illinois.gov. You can find everything COVID related there, and we're posting items there as soon as they're ready. There's also the normal process for distribution of provider and other notices. So in addition to the public health emergency, our state and our country have been grappling with issues around race, equity, health, and justice. These conversations are a long time coming, and we really have much yet to accomplish. HFS has been having these conversations internally as well amongst our diverse staff on better ways, not only to deal internally with each other, but also better ways to serve our diverse customers, and how to collaborate more with Black-owned, Latinx-owned, and other minority-owned providers and vendors. I know many of you are engaging in these conversations as well, and HFS really wants to be your partner. The delivery of healthcare and the ability of all communities to manage their own wellness is not equitable today. The inequities were really laid bare and more poignant than ever as communities of color have been disproportionately impacted by COVID-19. These conversations are really important, and we believe they must continue as you all do as well. I also want to let you know that internally, I've appointed an ad hoc health equity task force in the department. We are first focusing on racial equity issues, and our team is working together in two groups to make recommendations that we should take as an agency, both internally and externally. Another update, our team gave a presentation to the Legislative Medicaid Working Group 2 days ago about healthcare transformation and how we believe the state has many levers to use to encourage person-centered, culturally appropriate, community-based care. There's some funding reserved from the recently approved hospital assessment for this purpose. Our managed care partners have also been investing in innovative projects around the state. I gave a couple of examples of those at the virtual informational meeting that we had a few months ago. We really hope to use a data-driven and consumer-informed process to allocate these funds to better provide access to care in communities across the state. So pretty quickly, I'll turn the mic over to Kelly Cunningham, our Medicaid administrator. But before I turn it over, I just want to run through a quick list of the myriad of things the department is working on right now. Telehealth emergency rules, as I mentioned, for the pandemic and beyond. Appendix K for the 1915C waiver populations. A partially approved emergency 1115 waiver under the emergency. Disaster state plan amendments for Medicaid and CHIP, eligibility changes, postponing redeterminations, significant improvements on the backlog of applications, as well as long-term care admissions. Our caseworkers and those at our sister agency, the Department of Human Services, have mostly been working remotely since March and have barely missed a beat. They really have improved the backlogs there. We've also been working on COVID testing for uninsured populations and working to implement a new Medicaid-like program for low-income immigrant seniors over 65, as well as other programs that the General Assembly passed. We've been making remote patient monitoring and pandemic health worker programs available around the state. We worked with the General Assembly to pass the hospital assessment legislation and got it approved federally. We made the first payments to providers this month. And as I said, we're working to create a process to facilitate true healthcare transformation. We're engaging in conversations with the nursing home industry around quality, staffing, and nursing home rate reform. We secured a vendor yesterday to help us get CARES Act dollars out to impacted providers. We're returning pay for performance dollars to the Medicaid health plans so they can use those funds to support providers, especially behavioral health providers during this pandemic, as well as getting stability funding to other providers. We've gotten creative with the help of advocates and MCO partners to do things such as providing blood pressure cuffs for pregnant and postpartum women at no cost and without prior authorization, so that they're able to monitor their health from home and have telehealth visits with their OBGYN during this time. Our postpartum waiver for coverage for extending the 3-month coverage to 12 months is still pending with our federal partners, but we're still working on that. We are just about to roll out the youth care program on September 1 and are continuing planning for integrated health homes. So although we've had a number of retirements, we continue to hire the vital staff who are supporting all this work and supporting, ultimately our customers and mission. So I just wanted to talk through all those things that we've done together to help families succeed during this time. Please encourage customers that if they need to, they should still go to see their medical professionals. Things like prenatal care or monitoring significant conditions, for example, they can and still should access care where they are comfortable. And of course, always, access telehealth availability where possible. Of course, masks, I demonstrate, right? Masks are so important. Most healthcare facilities can help with these too. If someone doesn't have one available and someone is going to an appointment. Please also help our shared clients educate themselves on COVID-19 signs and symptoms. We have numbers and a text service where people can ask for help, hotlines where we can direct pandemic health workers and remote monitoring around the state. That's all available at the website that I mentioned earlier, hfs.illinois.gov. Finally, if Illinoisans have recently lost a job or had their hours reduced and might now qualify for Medicaid, as well as TANF or SNAP or other services, please encourage them to apply. They can go to www.abe.illinois.gov. We have streamlined the process to make it as efficient as possible for newly eligible folks to apply and to quickly access coverage during this pandemic. Fighting COVID is among our highest priorities, and so is creating a post-COVID system that we can all be proud of and that serves our customers equitably. Even though we hope this might be a sprint, we are in this marathon for the long haul on behalf of our 3 million customers and in partnership with all of you. So again, many thanks to those who are participating this morning, and thank you to those who registered and made comments. I hope we continue to have a good discussion today and beyond. And right now I will turn the mic over to Kelly Cunningham.
Thank you, Director.
Thank you, Director. This is Kelly Cunningham. I am the Acting Medicaid Administrator for the department, and I'm happy to have the opportunity to welcome everyone to the meeting and to echo our appreciation for all the work that you are doing. In terms of the agenda, I wanted to move on. I think the Director did a great job of covering everything we needed to cover on the COVID response and many of the steps that the department has taken since mid-March to position ourselves to act flexibly with respect to our administration of the Medicaid program in order to serve, to ensure that providers are able to serve our clients and eliminate barriers wherever possible. I wanted to move on to enrollment eligibility and redeterminations. This is a topic that we talk about fairly frequently during the MAC meetings and the MAC Public Ed Subcommittee, which was yesterday. And I wanted to see if Jane Longo would be able to provide an update on our current statistics.
Thanks, Kelly. I'm happy to report that the backlog of applications on hand, so these are individuals applying for coverage, is down to 17,000 at the end of July. This is down from a high of 147,000 at the beginning of, at the end of January of 2019. Much of that reduction is because of a lot of hiring we've done. Simplifications we've made because of COVID has allowed us to process more quickly. And in addition, during the COVID time, we're not doing redeterminations. During the emergency for COVID, we are prohibited by the federal enhanced match maintenance of effort requirements. We're prohibited from taking any adverse action on coverage for folks who are benefiting from Medicaid. So, that allows us to, we were able to really dive into the Medicaid backlog of applications. Well, we do have redeterminations on hand, and we do receive medical redeterminations from time to time, especially for those folks who have SNAP and medical benefits. There was a period I think in July where SNAP redeterminations were required to be mailed out, and for many people that meant a redetermination for medical. If they're found eligible, they're extended for another 12 months. If they're not found eligible, they will not be canceled. They cannot lose their coverage. But we do have 122,000 redeterminations on hand, and we're holding those for now unless they happen to be related to a SNAP. Because we don't want to take any negative actions on those. But even that's down from 192,000 that we had at the beginning of 2019. And then the only other topic I have is a new program for health benefits for immigrant seniors. This is the program authorized by the BIMP bill at the end of May, House Bill 357. We're working with our partners, DHS, DeWitt, and our vendor Deloitte, our IES system, our eligibility system vendor, to make the changes. We're getting ready to submit rules, state rules for the program. Individuals who are ineligible because of their immigration status can be covered if they're 65 years old or older and they have income at 100% of poverty level or below. That's about $12,000. It's almost $13,000 a month. A year for one person. This is a state-funded program. It is and we're modeling it a lot like Medicaid. Folks will apply for this program as they do the other, through AID and through phone apps or assistance from providers and others. There's also going to be help with DHS from DHS welcoming centers for immigrant groups. The benefits will be the same as Medicaid with the exception of nursing facility care. There'll be no cost sharing, premiums, or copayments. We expect that it's hard to get a number on the numbers of eligible folks, but we think thousands will be eligible. They'll have 3 months retroactive coverage as they do today. Our systems will be ready to take applications for the program on December 1st. So anybody who applies December 1st will have coverage back for 3 months. I think that's the gist of the program. And I'm not sure who's next on the agenda. Kim.
Yeah, I think Kim McCullough is next to provide an update on telehealth. And one thing I want to say about telehealth before I turn it over to Kim, I think Illinois, like many state Medicaid agencies, from what I've learned, has really taken advantage of the sort of the full breadth and depth of telehealth, using telehealth as a delivery mechanism for our services. Many Medicaid agencies, and we were no different, approached telehealth in the past with great caution. I think we were concerned about a lot of issues, program integrity, concerns about fraud, concerns about could services really be effectively delivered through a telehealth mechanism? And if so, what services would be most successfully delivered and what would those patient outcomes be? So as the director said in her openings, we've made a lot of advances in terms of telehealth, largely through rules that we were able to put into place at the department level. We did not need a lot of new federal authorities for this. So I wanted to hand this over to Kim to provide us with a more specific status report.
So thanks, Kelly. I am, in the interest of time, not going to take up much time to talk about telehealth because I think that you and the director have both done a great job in sharing where the state of Illinois is with respect to telehealth. I will just say that, you know, simply our update is that providers are still able to deliver services to our 3 million customers using this modality while experiencing, you know, what we're experiencing during this time. We're much like every other state across the country and expanding telehealth in a very rapid fashion. And as you stated, Kelly, it was a really interesting and robust, there were very interesting and robust conversations around telehealth over the last couple of years, and our figuring out the best and most practical way to modernize how services are being delivered in the state of Illinois by using this modality. I want to share news, though, about, and I want to speak specifically about HFS's Virtual Cares program. And that really is a program that is squarely in the telehealth space. And under the leadership of Director Eagleson, in concert with 3 partners, we stood up this program, which is a free program to Illinoisans all across the state of Illinois. It is available in all 102 counties. And the program actually provides virtual screening for COVID-19, along with tools, if you will, in order to practice safe care during this period of time, including remote patient monitoring, where professionals can help them to navigate the disease while they are sheltering in place and recovering. It's a very exciting program, and I do encourage you, those of you that are interested or believe that people are interested in this program, to visit our website where you can find more information about its availability. Now, as far as what's on the horizon, you know, as Kelly has said, you know, we rapidly increased our ability to provide telehealth during this period of time. But for those of you that are interested, you know, the Centers for Medicaid and Medicare and Medicaid Services proposed changes to expand telehealth just all across the country in a permanent way. And so we know that this modality is not going to go away. And the new way in which healthcare services will be provided will include telehealth in very meaningful ways. It actually creates an opportunity to open up access to various constituents all across the state. And we are, you know, certainly the Medicaid program will be at the forefront in having these discussions around how we move forward with respect to telehealth. And I would now like to turn it over to the next speaker on the agenda, Dr. Whitaker, the next person is actually Kelly to talk about integrated health homes. So Kelly, back to you.
Thank you. I'm happy to provide an update on integrated health homes. I think everyone is aware that this has been an issue and a program that the department has been working on for several years now. I think this is three. And what I want to share with you is that some work that we've been doing as we've been charged by Director Eagleson to really focus on a vision for integrated health homes. I think over the past, we have focused a lot on some of the federal regulations and requirements and tried to tailor our programs accordingly, with respect to integrated health homes. And what we have lacked until very recently is a really clear vision for this program. And what we as HFS right now, positioned right now, coming through a pandemic, but also in response to what I think we all have learned or have known for some time about social determinants of health and racial disparities and general healthcare disparities. We want the integrated health home program to really be strongly positioned to address where we see healthcare right now. So in light of the, this emergency, the public health emergency, but many other factors, we're going through and we're re-examining some components of integrated health homes with a renewed focus on addressing health disparities and inequities that have been magnified by the pandemic. We know social determinants have a significant impact on health outcomes. We want to make sure that the Integrated Health Home Initiative purposefully addresses within its design and within our strategies ways to more effectively address unmet social and environmental needs. One of the things that we're considering right now is actually looking at the eligibility criteria, particularly on the adult side. And I hate to get into the differences between the children's model and the adult model. That's kind of in the weeds. But what we thought we lacked on the adult side of the program was really a way to get at some of those chronic conditions that many adults suffer. And many adults suffer from chronic conditions and are at risk of suffering from additional chronic conditions. So we're trying to come up with a way to address that through our new vision. We're also looking at ways to refine our care management model to tailor services to complex individuals. So again, these aren't groundbreaking changes in the model, but what we're really focusing on is how to develop a more effective message and communication plan for what we're trying to get done, and then how to instill our vision in our MCO and integrated health home partners as they come on board. So that's it for an update on integrated health homes.
So Kelly, with that,
Thank you, Kelly.
Yeah, Kim, if it's okay,
go ahead, Dr. Whitaker.
Let us stop for a few minutes to see if advisory board members have any questions around the topics that you guys have covered, because it's a lot of ground we just covered. So any questions on enrollment, eligibility and redetermination, the telehealth update, or the integrated health homes update from the committee?
Yeah.
I think you can sort of speak out or raise your hand and Kim will see you, but I believe we could, if you have a question, just speak out.
Okay, so this is Amber. Can you hear me?
Yes.
So we have two questions. The first one I think might be shorter, so I'm going to start with that one. If I could ask about the new expansion for immigrant seniors, I would really like to know about why nursing home facility services are excluded, and I'm curious whether home and community-based services are included. So if you could clarify that, that would be great. That's my first question.
Hi, Amber. This is Teresa. The program estimates are, well, it's a fairly expensive program for the state because we can't get any federal match. And yes, we are planning to do the home and community-based services, but we are planning to do those at, as a standalone and not do nursing home care. It's just one way that we can design the program a little bit differently because we don't have to conform to federal regulations.
Okay, thank you for that clarification. And then, and that's all I need to know for the moment. The other thing is that Director Eagleson, you briefly ran over the effort that the state is making to apply for different COVID waivers. I know for sure it definitely perked up when I heard something about Appendix K for 1915C, but I'm curious if you can give us just a little bit more detail. I don't know if Kelly Cunningham is a more correct person to review what exactly is the status of those waivers, but I think a lot of people would really like to hear just a little bit more about that, if you could.
Sure, Kelly is our waiver genius, I will say, or guru, I will say. So I will kick it to her. Thank you.
Thank you. And I'm not a guru or a genius, but I will try to address some of these issues. So Amber, with respect to Appendix K, we did our first submission of Appendix K back in the end of March. I think it went in March 27th. And the Appendix K waiver amendments actually applied to all 9 home and community-based waivers that the state operates. And the waiver itself was approved on May 12th of 2020. And the full waiver document itself is posted on our website. The things that could be approved in an Appendix K waiver were changes in eligibility, assessments, timeframes around when assessments were delivered, the types of services that were delivered, and sort of a whole host of flexibilities. What we did with Appendix K really varied by, we work, first of all, I should say we work with our sister agencies who identified their needs, their specific population needs, and we incorporated those requests into our Appendix K submission. The submission itself was sort of a drop-down box where we were able to check a box and provide narrative. And it took about 6 weeks of work with federal CMS to get it approved. But the good thing is that it was approved May 12th. Again, depending on the waiver itself, what we requested varies a little bit. But we know probably one of the most beneficial things about Appendix K is that our approval would have gone retroactive back to the end of January. And we asked that it be allowed to be in operation for a full year. Many of the federal waivers and state plan amendments were limited to the length of the public health emergency. Appendix K was not. So we get sort of a full year to utilize flexibilities that we gathered or that we garnered through the approval. I can tell you we're working on a subsequent submission now. We've again been working closely with the sister agencies to make sure that their needs of their populations are being addressed. And so we're working on another submission now, which the feds allow us to continue to submit and to seek approval for additional items, rate changes in services, that type of thing. So it's kind of a constantly evolving document, Amber, and I hope I answered some of your questions.
That's fine. And I know I specifically asked about Appendix K, but I know that there's like a whole list of efforts that you've been working on. And so I just thought that we were going to hear more of like a complete update on like all of the different waivers today. And so I was hoping to get a little more details, just like what the list is,
Mm-hmm. Hi, this is Nellie. I would like to concur with what Amber just said. I was expecting an update on all the pending waivers, and especially for me, the 1115 waiver, which passed in May of 2018. I believe that COVID has given us an opportunity to fast track, several of the things that we've had on deck. And I want to congratulate you and thank you for the work that you've been doing at many levels, and especially with implementing the telehealth piece, which is crucial to addressing this. And also with the virtual cares program that was developed. So I'm curious, with the virtual cares, I like the fact that we're providing this information and screening and tools to help people navigate online, but have we done anything to make sure that we are looking at what other agencies are doing and considering how we're incorporating them into some of the resources that we're making available to the public? So for example, we've done some phenomenal work on the ground with IDPH and CDPH in response to COVID-19, where they've provided the funding to stand up within 30 days. We started the conversation on March 11th and opened up the first COVID medical respite for homeless and doubled up populations that has had tremendous success. I think this is a great model that can inform the work that was originally contemplated with the 1115 waiver in terms of really doing that warm handoff from institutional healthcare to a community-based behavioral healthcare system. It truly integrates the individual on a discharge plan. Also, after they've been deemed healthy, during, by the way, the medical respite stay, they're not only getting healthcare services and monitoring for their COVID, but they're also getting their behavioral healthcare issues addressed both in person and through telehealth. Behavioral health, and the discharges are leading to people to their ultimate best level of care. We've taken many people through that program to our system at A Safe Haven, where they've gotten much more robust services that are now moving out with employment and with permanent housing in a way that's truly stabilizing them on many fronts. So it is something that I think CDPH has been leading on, has been funding for all population, regardless of their ability to pay. And I believe is a great model that we should be considering for what we're dealing with right now with the opiate epidemic. So I'm also curious on an update on those numbers in terms of the opiate epidemic and what that looks like. I know in our last agenda, we showed that we had a 300% increase at the FQHC level, and want to know more in depth in terms of what that's looking like from a Medicaid perspective.
Hey, Nellie, do you mind if we have a subcommittee report that, can we address it at that time?
Oh, please.
The opioid question?
Yes, that would be perfect.
Okay.
But on the,
So you want to come back to that?
Yeah, but on my question on what we're doing with HFS virtual cares, are we doing anything with IDPH and CDPH to kind of learn best practices in terms of what's happening right now and making sure we're making resources available to those that are making inquiries?
Kim, do you want, we are working with IDPH very closely, including to refer people who either call the IDPH hotline or text their zip code. I don't know if Kim wants to say any more about that. And then I also want to take this opportunity to point out that Alejandro has been raising his hand, so I've put him on the docket next.
Yeah, I've got Anne, Marvin, and Alejandro for questions next, okay? So you guys can help me out here. I've got a list. I'm going to come to your questions.
Great.
I think Ann Lundy might have been next since she had an eligibility question.
I want to let Kim say about the public health coordination. Is that okay?
Oh, yes, ma'am. Yes.
Yes, and also the 1115 waiver, if you don't mind.
So I'll answer the question with respect to the virtual cares program and the coordination between the Illinois Department of Public Health and HFS. We actually presented before all of the public health departments, the local public health departments across the state, so all 102 public health departments, to talk about the virtual cares program and provided them with literature so that they could then link any potential patients or customers that have either been COVID-19 impacted or actually have, contracted the disease with our virtual cares program. So that is in motion, and we meet with them on a regular basis talking about the program. We're also a part of their equity task force, which I believe that you also sit on, Nellie, and we work with them, again, very closely around the things that are related to COVID-19. We have information about the program posted on our website. We also have the information posted on the governor's office COVID page. It links directly to the 3 organizations or entities that are providing the services all across the state of Illinois. And we are also embarking on various marketing campaigns targeting the communities that are significantly impacted by COVID during this time. And I'd be more than happy to talk to you in greater detail about the work that we're doing, you know, at your convenience. So thank you very much.
Thank you. Let's talk.
Anne, you had a question about eligibility.
Yes, thank you, Madam Chair, and good morning. Director Eagleson and team, first of all, just briefly, I just want to acknowledge and thank you for all your efforts during this time. It is certainly well noted, and we've also recognized you've had the sense of urgency. Not only have you maintained, but you also have continued to innovate and transform. So gratitude for you and to the team during this time. I would also like to suggest for consideration, also appreciated hearing from Kelly in regards to integrated health home and, you know, really truly having the vision for that program. Has there or could there be some consideration for beneficiaries to have a smartphone device to support telehealth, video telehealth, self-management, and also assistance with any remote monitoring? We have at Access, we've been running for about 3 years a pilot integrated health home. This is one area that we believe could really, for this high risk population, could really assist with some better outcomes. Thank you.
Thank you, Anne. Marvin?
Yes. Good morning, everybody. I'd like to start by echoing what Ann said about the department. I know that Kelly Cunningham has been more than available to the behavioral health care community throughout this COVID. And we have worked through a lot of issues, and she has been more than receptive to working with us. So I like to just personally thank Kelly. I have 2 questions, and one of them is to Jane Longo, just to get some clarity on the redeterminations that's on hold, the 122,000. What does that mean?
It means that we had sent out a form asking individuals to give us information about their eligibility. Every month, about just under 40% of the people that are up for renewal, we can verify all of their information electronically, and we just send them confirmation that they've been extended a year for coverage. But for the other 60%, following pretty specific federal guidance, we have to get information from the enrollees to verify that they continue to be eligible. And so before March, we sent out these forms every month and would get them back. Once COVID emergency started, we stopped sending out those monthly forms. So they're primarily old forms. There's some that are because of SNAP, or people are very, and sometimes they have assistance from providers and others. People are very ahead of things and send the form themselves. But we're not taking any action on those. And when the time comes to start up new redeterminations, once the public health emergency is over, those will probably be so old that we'll ask for new ones.
Okay, so it would be after the emergency is over then?
Unless Congress changes the maintenance of effort requirements.
Okay. My other question is on health homes. Kelly, and you mentioned, and I know we've been talking about this lately, and you mentioned about chronic conditions and at risk of chronic conditions. And to me, that sounds more in the terms of prevention. So is HFS willing to go more towards prevention? And I bring that up because of the health disparities. And I was glad to hear that you're working on a strategic plan and you have the ad hoc work group, and you'll be sharing that information with the committee. But in addressing those health disparities, there's a lot of information and literature out there around prevention. So just wanted to get an idea, is HFS really thinking about going in that direction?
Right. Thank you, Marvin. And thank you for your kind words as well. And we have been talking about that. And I think you've hit the nail on the head. That really is one thing that we're trying to figure out how to tailor this program, to address those risk factors, which might incorporate prevention. We're still kind of sorting through how we want to operationalize that now. We don't have that all sorted out, but I can assure you that's a direction that we would like to incorporate in the model. I also wanted to, just while we're taking questions from MAC members, just to share in response to Nellie's concern and to Amber's as well. Laura Phelan, who is on the HFS team, is able to provide, if there's time, an update on all of our COVID waivers and state plan amendments. She's kind of the keeper of that information, has played a critical role in helping us move forward with our requests. So she'd be available to provide detail on that if there's time in the agenda.
Yeah, Kelly, we would like that. Why don't we have Alejandro, Dr. Clavier, ask his question, and perhaps Laura could give us some of that information.
Thank you.
Alejandro, Dr. Clavier.
So 3 quick comments. First, on behalf of every provider on the state, thanks to the department for allowing telehealth. It's been amazing for providers, for patients. So thank you very much. And I'm happy to hear that's going to be maybe become permanent, because it's an amazing way for providers and for patients to be served and to serve. So I'm very happy for that. It can, well, that's really short. Second, I think the recoups that Dr. Moverham talked about, I don't know if it's illegal, but it's certainly unethical. So providers are not making a mistake, and providers are being penalized months later for seeing a patient who was eligible at time of service. So that's something that we talked about in our February meeting, and there was an example of the state of Texas stopping recoups until they figured out what was happening. So I think that's something that we should please look into. And third, I'm fully, and we're all here, all fully for increased access and create equity. And I think one of the biggest ways we can create equity is to increase payments of Medicaid visit rates. Medicaid visit rates haven't been increasing over 15 years. Everything else has, except Medicaid rates. So we want to create access, we want to create equity. We have to increase CPT rates, visit rates on the Medicaid system. So we're creating unequal access because some providers can't see Medicaid patients because of the super low rates that haven't been increasing maybe in 15 years, some over 20 years. So that I wanted to say. So thank you very much.
Thank you, Doctor.
May I address the rate issue just briefly?
Yes. Yeah.
So one thing that I didn't mention, that as a part of the hospital assessment that passed in May when the General Assembly came back, one thing the department had asked for and that we ended up getting everyone to agree to was that we would kick in some general fund money from our budget, but also the hospitals increase their assessment. And we are now raising all physician rates to a minimum of 60% of Medicare. I know that's not far enough, but it's progress. So I did want to announce that, and that's in the I think we've posted those fee schedules on our website recently, and did want to make that point. So
when does this take effect?
It takes effect retroactively to July 1st.
Okay, and the ultimate goal, I hope, for everyone would be Medicare parity. That would be fair for everyone. Thank you.
Director Eagleson, is this a permanent increase, or is it sort of an emergency COVID increase, or is it for a year? How long would that be in play?
This is a permanent increase to physician rates.
That's awesome. And it includes, when you say physician, does it include primary care and specialists?
We were trying to get, because right now the way our rates of, it depends on when the service came online. In other words, if like something came online in 1999, it was set at 60% of Medicare in 1999 or whatever, you know, to Alejandro's point, a lot of things haven't been changed. So we were trying to raise all boats, if you will, to that 60% mark. And it, just to give you a little bit of an idea about how much it cost us just to get there, it was about $150 million annual costs. So progress, again, you know, we're trying to do some of these things slowly, but just wanted to put that out there. It is a permanent increase. It is now part of our permanent fee schedule.
Is that fee schedule
so
up?
Director Eagleson is Dr. Huggett, Dr. Clavier, myself, all primary care doctors on the ground. And I will say, also with the MCO experience that we've had, that, getting access to specialists and to even primary care in some instances is challenging because, not all docs want to take Medicaid. You've heard some of the concerns that Dr. Clavier has sort of brought forth. You heard some of the public speakers. It makes it difficult. And so from an equity perspective, I do want to say this gets us closer. And, I think all the primary care docs practicing are going to breathe a sigh of relief that, the state and the department is investing in them and the work that they do on the front line. So thank you. This is really great news. And I hope the committee will agree. Any other questions from the committee on the, yes, Director?
I'm sorry, I stand corrected. We sent out the provider notice with the information, but the fee schedule is not up yet. So it will be soon. I apologize.
That's okay. Thank you.
Can I say something? This is Nellie.
Yes. Hi, Nellie. Yes.
Hi. Considering the fact that we have 25% of the population on Medicaid that is diagnosed with behavioral health care issues, and they traditionally account for over 50% of the cost, has there been any thing that's been done to address and benchmark community-based behavioral health care treatment providers in terms of our reimbursement rates?
Hi, Nellie, this is Kelly Cunningham. I can tell you that we're in the process of implementing 2% increase in community behavioral health rates and super rates, largely driven by increases in minimum wage. Those rate increases, when they're approved by the federal government, will be effective July 1st.
What was the methodology for coming up with a 2% increase? Was there any benchmark used to compare the services that are offered at the community-based level in terms of, similar industries such as nursing homes, in terms of providing assisted daily living services, shelter, nutrition, education? I mean, obviously, we part from there to job training and things like that. So was there anything that was used as a benchmark? Because we too have not seen increases in over 20 years to really account for the real costs of treating the whole person with the services that we provide.
Okay. Yeah. As I said, I think the 2% was kind of geared back towards minimum wage increases. I do know last year there was a 2.5% increase. I know that these sound relatively small in the scheme of things, but they apply to all community behavioral health services. As for methodology, I can also tell you too that one of the things that we're undertaking at HFS and trying to keep our eyes on are always those state-by-state comparisons between our Medicaid service rates and other states' Medicaid services rates, particularly in behavioral health.
Okay, can I just suggest that we take a look at that, because, in Chicago, we went from an $8.50 minimum wage to an $11 to a $13 to a $15 wage increase. And that is much, much more than a 2% increase, obviously.
Thank you, Nellie. Are there any other questions from the advisory group?
No, this is Tom Huggett. I do have a quick question, Chair.
ID yourself, please.
This is Tom Huggett.
Oh, hi, Doc.
Hi. Thanks for all of the work to the department. We were kind of talking about behavioral health and primary health care integration, I think, with the integrated health homes. I know that CDPH is working very hard on this, Dr. Jasmine, Matt Richards, and other people. I'm wondering how the state is perhaps coordinating some of those efforts with CDPH and other health departments in the state that are really looking at racial equity issues in trying to combine primary care and behavioral health, especially in response to crisis situations. So we could respond to a mental health crisis with people who are trained in mental health crisis rather than relying on police who, even though that we may have CIT workers, they're not always available. My direct question would be then, as we're working on integrated health homes, how much work are we doing in trying to work with people like CDPH to integrate primary care and behavioral health for at-risk populations?
Hi, Dr. Huggett. I can tell you that we're definitely focused on the issue of looking at sort of non-traditional Medicaid outcome measures to measure and benchmark where we're going with integrated health homes. So things like school attendance, reduction in jail time, those types of things. We're in the process of developing those right now and getting those benchmarks set. So we definitely agree with you that those indications are really important as we move forward with the program. Again, that I think speaks to the visioning exercise that Director Eagleson has charged us with, is to look at some of those other outcomes, those social outcomes, those, employment outcomes, other things like that as we take this program forward. So that's something that's really important with us. We haven't worked closely yet, like with the CDPH or individual partners on this yet, because I think we're still trying to get our arms around it ourselves. But that, those are excellent suggestions, and we'll definitely take those to heart.
I'm just also aware of, just to follow up quickly, I'm also aware that you're also very conscious of very high utilizers of Medicaid services, especially with hospitalizations. We have one index case that was, hospitalized, had 62 ambulance runs in 60 days in the city of Chicago. So I know that this is a high utilization, we want to do something and make sure that the people who are utilizing Medicaid services really get the care that they really need and deserve, rather than reimbursing for, those types of high cost things. So I'm glad that we're working on that, and I hope that housing is also part of that.
Thank you.
Thank you, Dr. Huggett. So just, guys, this is great dialogue, and so far so good. We're at 11:32, and it looks like let's say we might go over about 10 minutes. And Kim, is that allowed if we take this over about 10 minutes in terms of the technology?
Kim is saying yes. This is tech support. She got logged out of the Zoom.
Okay, great. All right, thank you. So if that's okay with everyone, let's keep moving. I think we can kind of push through here, but we may go over just a few minutes. Laura, did you, were you able to just give us maybe 2 or 3 minutes on sort of just a specific kind of waiver spot update? I think that's an issue folks who are interested in. So Laura Phelan, if you're available, please come forward.
Can you hear me?
Yes, we can.
Okay, great. And I'll keep it brief. So just to walk through them all, for the 1135 waiver submission, and the 1135 waiver was largely flexibilities directed towards providers. And for that waiver, we've been able to implement various pieces from different authorities. And so there were 3 different pathways. One was the 1135 partial approval. And that we submitted the 1135 request on March 19th. We received the partial approval on March 23rd. They were generic paragraphs that federal CMS was sending to any state that requested any of those flexibilities. So they didn't necessarily match our request. But we've continued to tell providers to follow the HFS provider notices so that they can implement flexibilities as Illinois is implementing them, because we're not, required to implement it in the way that CMS sent it back. We're implementing them in the way that we requested them for the most part. Also on March 30th, CMS began releasing blanket Medicare waivers that they later qualified also applied to Medicaid, which meant if a policy was in that blanket Medicare waiver, that a state could choose to implement it in the Medicaid program without seeking additional guidance. And those blanket waivers covered a large portion of our 1135 waiver request. And some examples of those was allowing non-HIPAA compliant modes of communication for telehealth, like Skype or FaceTime, provider payments for care in alternate settings, long-term care nurse aid training and certification flexibilities, and items like that. And then there was also a CMS concurrence, which allowed us to have additional time to process state fair hearing requests as long as those requiring expedited action are still prioritized. There were two that CMS determined were not approvable to waive. One was the ordering, referring, and prescribing requirements. And as a result, after we received that from CMS, after a couple of appeals that weren't successful, we sent out a provider notice about turning that edit back on. And then also implementation of the electronic visit verification systems. We're not able to delay the federal requirements for that. And then we're still awaiting CMS determinations on some items, such as billing flexibilities for school-based health centers, as well as pursuing different pathways for some, such as retainer payments for day service providers who are serving beneficiaries who are not in an HCBS waiver. We're in discussions with CMS about submitting an amendment disaster SPA to get that authority through a different way. And similar to the Appendix K, like Kelly said earlier, this waiver also is evolving. We can continue to submit requests as needs are identified. For the 1115 waiver submission, there was one item in our request that CMS determined we did not need 1115 authority for, and that was waiving the MCO 30-day choice period. They sent us an email concurrence saying that we could move forward with that request without waiver approval. And that is something that we have implemented. All Medicaid beneficiaries still have their 90-day switch period once they're enrolled, and they also can still choose a different MCO before their MCO enrollment date, but it doesn't have to be 30 days to make that choice. And depending on how close to the first date of enrollment, it might become effective the second month. That's something that we're implementing right now. And we're also going to formalize it in an MCO contract amendment and the disaster SPA amendment language. And then the rest of our 1135 waiver requests, unfortunately, CMS has verbally informed us that they are not going to be approved at this time. The state is not going to receive a letter that formally denies them or formally makes any federal determination on them, because technically they are still under review at CMS. But staff have verbally informed us that they're not going to be approved right now. I think Kelly spent a lot of time talking about the Appendix K. For the Medicaid disaster SPA, as well as the CHIP disaster SPA. Those were many of the eligibility changes that we were making, including expanding the frequency of presumptive eligibility for children and pregnant women, giving the state presumptive eligibility authority that has really expedited enrollment, suspending premiums and copays for programs, and then also some rate increases to ICFDD and MCDD facilities since day service providers are closed. Those were all approved by CMS and are posted on our website. I mentioned the potential additional disaster spa request for retainer payments when day service providers serving someone who's not an HCBS waiver member, also formalizing the MCO enrollment change during the public health emergency. And similarly to the other 1135 waiver or Appendix K, we can continue to submit amendments as the needs are identified. And then there were also the list of CMS concurrences that I know we received those pretty early on April 13th. And I think Jane has, in MAC subcommittee meetings, Jane has gone through those in detail. But as an example, there were a bunch of eligibility concurrences, such as allowing self-attestation of income and incurred medical expenses, and then an MCO, the MCO enrollment concurrence, and then the state fair hearing concurrence that I mentioned as well. And then finally, there's an MCO contract amendment that MCOs are currently implementing all of the policies in now. However, it's going through the formal contract amendment execution process, which also includes a formal CMS review and sign off. And things in there include the modification to the 2020 pay for performance framework that the director talked about earlier, adding a risk corridor to address the impact of COVID-19 on the utilization of covered services, formalizing the MCO enrollment change, and then also requiring MCOs to pay out-of-network providers as if they were in-network for COVID-19 services. So that is the I guess, a quick download of where we all are with all the various COVID waiver and SPA flexibilities.
Thank you, Laura. Any questions from the committee before we go back to Kelly Cunningham, our Medicaid administrator, to update us on long-term care facilities?
Samir Vor, I have
This is Kai.
question.
Oh, okay, go ahead.
I think I have two questions.
Kai, go ahead.
No, Samir, go ahead. I'll go after you.
So, part of, I think, my question, Laura, especially with CMS, is with each state's kind of unique and different circumstances, has CMS has it been sort of universal in the way that they're kind of making those determinations from a state-by-state basis, or has it been their flexibility based on kind of individual state needs?
Mm-hmm. Probably a combination of both. So for example, the school-based health center request seems like that one's taking longer for the 1135 because it appears that we're the first state that's requesting that flexibility, and CMS is trying to figure out what their policy decision is on it. For the 1115 waiver, they told us that many states were in the same situation as us. A lot of the items in our 1115 waiver, we weren't the only state that requested them in regards to like home delivered meals or housing for individuals experiencing homelessness who need a place to go during the quarantine. Other states also requested versions of those, and they've been consistent in verbally not moving forward with them, but formally not sending anything written. The one thing I should have noted was we've tried to be creative where we could to make sure that we get the flexibilities that we need to the extent we can. And so, for example, the MCO P4P modification, we used that in a way to try to address some of the waiver authorities that we had asked for that we didn't get formal approval for. So, for example, by telling health plans to look at Medicaid beneficiary needs due to the COVID-19 public health emergency, the MCOs are putting that P4P money towards housing for individuals who are experiencing homelessness or don't, maybe can't go home because of their living situation and putting other family members at risk. More home delivered meals, in some cases made large grants to food banks. And so it was a way to take, it was 1.5% of the capitation, and it was a way to try to take money that we could control through our MCO partners, because it was their initiative, them choosing what they wanted to do with the money, but also align it with some of the needs that we were seeing that and that we were concerned about, that resulted in our initial waiver request.
All right,
Thank
Laura.
you.
Thank you. Kai?
Yes. Hey, Laura. Thanks for the update. Just clarify, I know you didn't specifically call out, even though you did a pretty darn good job of being as exhaustive as possible with your long list of waivers. Can you give us an update and what is the action plan, I guess, for if we have one for the 1115 waiver that extends the postpartum care as a delivering provider of all Medicaid patients? That was one, I constantly hear about, and I even have providers thinking it's active, because I think at one point it seemed like it was going to go into effect. And I have to remind people like, no, don't tell that patient that, her chronic care, we got to stop and manage it now, because that is not active. I'm not sure how that happened.
That is currently sitting with federal CMS under review. Unlike a state plan amendment, unfortunately, they aren't on a clock for an 1115 waiver, which is also how they could, for a COVID 1115 waiver, choose to not send anything in writing, even though they've verbally told us nothing's coming. That is not the case for the postpartum one. They haven't verbally told us that a decision has been made. Instead, what they've told us is that their priority currently is COVID-19 related needs, and that they are addressing other state requests as time allows. We've pushed back pretty strongly, asking for a date and timeline, and making the case for why the need is there and why it's important, but they have declined to provide a date or a timeline to us. We do, however, continue to work on it. We actually applied for and were selected for technical assistance through the National Governors Association Health Team, as well as SHADAC, which is a data group out of the University of Minnesota, for states who are working on 1115 waivers. And we have a team of HFS and Department of Public Health staff that meet with them monthly, that are continuing to refine our metrics and measures within the waiver in regards to how we'll measure success and progress it, so that when a CMS does come back to our 1115 waiver, we'll have, because that's a normal part of the negotiation, but usually towards the end of the process, we want to be as ready as possible to move through that part of the negotiation quickly.
Thank you, Laura. But in terms of sort of pregnant women and sort of continuity, we're not terming people right now because of the COVID emergency. So in some ways we have a quasi, I'm going to call it, a duct taper in place we are sort of addressing this issue, right? Because we're not terming people actively because of the COVID emergency.
I believe they're still losing coverage after the ballpark 60 days, right? If they didn't qualify for regular Medicaid.
So I'm just asking HFS to.
Jane, are you still on? Jane or Laura? Didn't the Fed specifically make us change this?
No, they've directed us about women on the CHIP who are covered, non-citizen women who are on CHIP, but otherwise everybody is staying on even past the 60 days.
Right. So it depends on your immigration status.
Right.
Other than the non-citizens who get their prenatal and delivery care through CHIP, that group, other than them, women are staying on past 60 days.
Right.
Cal,
Did you, I just want to be sure that you,
Yeah.
there's two, I'm asking, this is a separate track, but the women are still covered. So that's, it's not what we, but in the interim, we have sort of a quasi solution, if you will, duct tape on this particular issue.
And I should clarify, we have not cut off the women who are on CHIP either, but we've been told we should. So we have that programming yet to do in the system, and it's in our priority order to get it done. But it's not active yet.
Okay. So we're going to move. It's 11:50. So we got 20 more minutes, I hope. I know we did start late, so I'm going to ask your indulgence here because this is a really extraordinarily substantive update that we're getting here. Kelly, can we move on to the long-term care facilities update?
Absolutely, yes. So in terms of long-term care facilities, and I believe the requests around updates for long-term care facilities related to the COVID epidemic. So I wanted to briefly just stress to everyone that HFS is working really closely with our partner agency, the Illinois Department of Public Health, who is the lead working with the Centers for Disease Control on many of the policies that are governing how COVID is handled and responded to in congregate and long-term care settings. We participate in a twice weekly meeting with public health and all of the long-term care associations and some of their providers. And these meetings started back the end of March and early April to specifically discuss strategies and guidance issued by CDC that can impact long-term care facilities. So we're a real active partner, in those discussions. We get pulled in a lot for questions around payment and payment reform and how we're addressing issues like that. I can share that some federal or some long-term care providers, it really depends on the provider class, have received federal CARES Act money directly, either through what's called the Medicare tranche, or in some cases the Medicaid tranche, to address increased costs that they have incurred associated with purchase of PPE, staffing and that type of thing. HFS also received an allocation in the budget which passed the General Assembly back in May to pass through some additional CARES Act funding to long-term care providers, hospitals, and other Medicaid providers. And we're working on developing an allocation for each of those provider types now to get that money out. So, but back to long-term care, I just wanted to stress that we work closely with our partners at Public Health. We take a lot of lead from the governor's office on this. As well, the governor is, deeply concerned about the impact of COVID in long-term care facilities and other congregate settings. And just to say that it's something, we take very seriously in terms of our impact on it and through public health's impact on enforcement. So, thank you.
Kelly, that's actually really helpful. And just to confirm and to be sure everyone understands that public health regulates the nursing homes. Is that correct?
Yes, that's correct. They're the licensure and certification agency.
Mm-hmm. Yeah.
Okay. So that's very helpful. Any questions from our committee on the long-term care facilities update? Yeah. And I can't see you. I can't see your hand. So you'll have to just speak out.
This is Amber. I want to thank Kelly for providing that update. And I appreciate knowing that there is a lot of, weekly contact between HFS and IDPH on the problem about COVID and long-term care settings. I would just point out, though, that I don't think the problem is necessarily COVID. The problem is long-term care settings and whether or not they were ever prepared to be able to handle a pandemic or disease in a way that was adequate prior to the current situation. I have to say that I am upset about the fact that the governor's office moved to make sure to provide immunity to nursing home providers very early on in the pandemic. without consulting with people who are patient advocates or anybody that didn't have a monetary interest in making sure that the nursing home survived. That is a problem. And there may be people on this committee who have a very different view than I do on this matter, but that was a problem. And I understand that it's really IDPH that has oversight over this, but HFS does get to control where Medicaid dollars get spent in the state. So I think that there is an obligation on that front, right? I mean, it's just, there it is. I would just urge to this committee that, you know, what are we doing with people who qualify for long-term care services? You know, like where are the investments that we are making? I appreciate that Appendix K has been used to provide emergency services for people who are relying on community-based settings. But the fact is that, like, people are in an uproar over the deaths in nursing homes. And, you know, anybody that has worked with providers who are trying to provide services to people in nursing homes have been worried about sending their employees into death traps, you know. So, I mean, that's basically the situation that's being faced. And then there are people in the nursing homes who maybe they don't know what's going on, you know, but there are people in the nursing homes who do know what's going on and they want to get the hell out of there. And unfortunately, nobody has really come up with a good answer for how to handle what to do in a pandemic with people who are in long-term care facilities. And I was just pointing out that right now our country's response is basically like, just leave them in there, lock them in. And that's not right. So I do hope that in a more long-range, you know, view, that this close coordination between the state agencies continues to happen, but there has to be also a discussion with the Illinois Emergency Management Authority and of course the DHS about how to manage these kinds of situations, because I feel like, you know, the deaths are on us for not providing structural supports. I mean, yes and no, but there's something wrong here structurally that has resulted in a lot of people dying. So that's uncomfortable to say, but I feel I need to put it out there. I appreciate you listening to me about it.
Amber, so noted. And thank you for your comments. Are there any other questions or comments from our advisory board before Kelly wraps up? Okay. You know, guys, this has been tremendous, right? So let's continue with Deputy Director Robert Mendonza for an update on the Medicaid managed care programs. Going to do probably kind of a brief highlighted proposal given the timing here. Director Mendonza, are you there?
I'm here, Dr. Whitaker, and I will try to be very brief. I'll start with youth care. So HFS is adding valuable care coordination and new services for these youth. While families are currently on their own to connect with providers, under youth care, they'll have a personal care coordinator to reach out to providers for them and schedule appointments. Youth care also has more providers enrolled than ever before, more than 3 times the amount that are currently available. And HFS has been monitoring and working with parents and stakeholders for months to improve the program, and we are prepared to launch September 1st. So that's youth care. Just to be quick on the current state, just want to talk about the transfer of membership from Next Level to Meridian. I just want to be clear that this was not an acquisition. So Next Level will be responsible for paying claims for all services rendered through June 30th of this year. And they will remain in operation to service providers and pay those claims until all the claims are paid. So I just wanted to be clear on that. And Dr. Whitaker, if you want to add anything, please feel free to do so. The membership was all moved to Meridian effective July 1st, and Meridian will be going forward responsible for all those members and for paying all those claims, but they were all our Meridian members as of July 1st. And Dr. Whitaker, if you want to add anything.
Yeah, you know, I'll be happy to add that our website's still up, provider portal's still up. The ways to reach us are still up. So, so far, I don't believe we've had any issues. We've been, I think, pretty responsive in reaching out to providers who've reached out to us with any questions or concerns for any services delivered via up to June 30th. That should go just fine. And then, also just happy to say that we'll be continuing to manage through a care coordination agreement with Meridian, several thousand of our highest risk members. So we're excited to still be involved in the program, albeit in a somewhat different role, but as a delegate to Meridian. Thank you.
Thank you, Dr. Whitaker. And the last thing I've got is just to make everyone aware that we're still planning to roll out MMAI statewide July 1st of next year. It'll impact approximately 43,000 individuals, and obviously much more to talk about as we get closer to the date, but just wanted to update the group on that.
Any questions for Robert on the Managed Medicaid program? I know we've covered some issues already, but any questions from the advisory committee? And just speak out because I can't see you. Okay. All right, hearing none. Thank you, Robert. We're going to move to our subcommittee reports and just we have a brief kind of summary from each committee chair. The Public Health Education Subcommittee report, I believe we received a written update by email, but can the chairman speak up, please, and highlight any areas you'd like to do so?
Sure. Thank you, Dr. Whitaker. This is Kathy Chan. I help chair the Public Education Subcommittee. We have met 3 times since the last in-person convening of the MAC in April, June, and then just yesterday for those of you who were able to join us. The draft approved meeting minutes for the April and June meeting are on the HFS website, so I'd encourage anybody who wants to have more details as to what was discussed to go to those meeting minutes. They are very comprehensive in nature. We discussed a number of standing agenda items, many of which were already covered today, so thank you, Jane, for providing updates on redetermination and the initial application process, as well as the new coverage group. The 2 things that I want to highlight from our meeting yesterday were that we had a very brief but important presentation from Dr. Paula Allen Mears, who's the Executive Director of the Office of Health Literacy at the University of Illinois at Chicago, who provided an overview of her office's work on health literacy and just interest in supporting the work of the Public Education Subcommittee by sharing best practices. And her information and the information of her office is going to be included in the meeting minutes for anybody else who's interested in learning more. I also want to acknowledge that a provider notice that HFS published June 22nd regarding Medicaid and persons entering and exiting the Illinois Department of Corrections. And that provider notice was very welcome by members of the subcommittee, as the justice involved population has also been a standing agenda item for the subcommittee, including making sure that individuals who are being released and returning to communities from the justice system are appropriately connected with both Medicaid and the available services through Medicaid. And so that provider notice helps clarify for providers how those benefits are restored for persons exiting DOC. Our next committee meeting is scheduled for October 1st from 10 to noon. Thank you. That concludes my report.
Thank you, Kathy. Your report is submitted to the record. For the next, the Quality Care Subcommittee, Ann Lundy.
Yes, hello everyone. So the Quality Care Subcommittee, we last met in person on February 26th on Clinton Street in Chicago, and then virtually with Springfield. It seems like a very, very long time ago. But anyway, we reviewed the 2018 Illinois Health Choice Quality Report Cards. And we had as a guest to help us with that Health Services Advisory Group, who actually completes, if you will, and explain the methodology behind the Health Choice Quality Reports. And so that was shared with committee members in great detail. We did not have any recommendations come out of that, with the exception that we're looking forward to reviewing the 2019 report cards, hopefully in the fall, October timeframe of this year. We also had presentations from the managed care organizations as far as how they're addressing quality, and particularly areas where their quality was unfavorable, and written presentations, and which will be provided on the website, were provided by County Care and Aetna Better Health. Our next meeting is scheduled for August 26th, which we'll be doing virtual. And then also at that time, we look to be discussing further quality measures that will be incentivized for the year of 2020. And the committee also has a desire to look outside our borders, if you will, to other states to see if there's some best practices that we can hear about, and then again, come forward to this committee with a recommendation, ultimately then that recommendation on to HFS. So this concludes, and I also provided a written report to the committee, but this concludes my report for today, Madam.
Thank you, Ann. Your report is submitted to the record.
Can I ask one question, Cheryl, to Ann? And this is around the report and the one with the two managed care companies that they talk about ways to improve upon some of those outcomes. And my concern is really around behavioral health care.
Well noted. And so I certainly can bring that up at our meeting later on this month.
Okay, thank you.
Kelly, there's our next agenda item is a department status on opioid recommendations and federal grant.
Right, I can address that briefly. Wanted to explain to the committee we're in the status of kind of a transition status right now in terms of our staffing on this particular area. Dr. Maria Bruni left HFS, went back to the private sector effective June 30th. So we're in the process of trying to bring on somebody to oversee this grant for us and to bring on some additional staffing resources. So I don't have a formal report today to be able to offer on this topic other than that, but we can definitely have more by the next meeting and we'll be happy to share it.
Okay, great. Nellie, I know you had a question about opioid crisis numbers and an update. Did you want to speak any further to that topic?
I think Nellie had to drop off. She said she had to leave at 12.
Okay, understood.
This is Tom Huggett. I can guess what Nellie is saying. Just talking about the CDPH health alert that came out on June 30th with a 67% increase in ambulance responses to overdose and a 46% increase in overdose deaths in Chicago over 2019. We really need to see how HFS and the Medicaid program in Illinois can really respond to this and to the recommendations that that our subcommittee put forth last year in terms of payment models, withdrawal management, and the old detox programs. And so I understand with Dr. Bruni leaving, there's some flux, but we kind of have an epidemic within a pandemic right now. And so I'm really hoping that the department can move on this issue so we can align and motivate and incentivize up-to-date incentives and reimbursement mechanisms so people can get the care that they need rather than detox. Detox just does not work anymore with the level of heroin and the amount of fentanyl. You cannot detox a person in 3 days and have them go out and have any success at all. So I'm really hoping that we can, the department can move on this as quickly as possible.
So Dr. Huggett, the next agenda item is Medicaid Advisory Committee recommendations. And it sounds like you're making a recommendation to the director of the department.
I guess the recommendation would be, the MAC already made a fairly firm recommendation with our opioid opioid recommendations, and I really hope that these can be taken up. And if we can have the recommendations also ask that the department have regular reports back to the MAC about this. So Chair, I guess I'm wondering if maybe Kelly, if you could give us kind of a time frame on this, because this is really an issue for many of our Medicaid recipients.
Right. In terms of staffing, I know that I think we're pretty close on bringing on some staff support for this program, hopefully within the next couple weeks to a month. So I think we'll definitely, be able to pick up the ball and run with it a little more effectively. So thank you.
Thank you.
Just in follow-up, Chair, if I could just ask Kelly, have there been thoughts or, about realigning reimbursement, especially for detox programs?
We're always wanting to make sure that our incentives are properly aligned, to address the behavior that we want. I can't say specifically that I'm aware of anything with respect to the detox programs, but I'm certainly aware that this has been a concern for a long time, and I appreciate what you shared about the lack of effectiveness of those programs. So I think we can definitely take a look at this and make sure that we're getting it addressed.
So Dr. Huggett, we have a section on committee recommendations, and perhaps we can ask the department to take this back and for our next meeting to come back to us with kind of, a substantive update. To your point of this being an epidemic inside a pandemic, I mean, this is kind of an area that is important to many of us, right? We're seeing kind of the public health impact of it. So we can submit to the director some recommendations for things we'd like to particularly hear about on the next meeting. We realize you may not be able to solve them by the next meeting, but any kind of interim update would be helpful, I think. To the advisory committee, do you have any other recommendations for interim updates or things you'd like to hear about the next meeting? This is your time. Just speak out because I can't see you raise your hand.
There was one thing that I have, Dr. Whitaker, and that was there was a value-based payment report that was supposed to be submitted to the General Assembly in December, and just wanted to know the status of that at our next meeting.
Okay. Update on the value-based report. Submit to the General Assembly. So please capture that in the minutes.
Cheryl, I'd like to, this is Kai, if we can just make sure your update on a SPA that was discussed for family planning for the state.
Kai, say that again?
A state plan amendment for family planning. And if that's going forward, if we can get an update on that too.
Very good. Any other recommendations or things you would like to hear about at our next meeting?
Same, just continue the status of telehealth and the recoups. That will be important, just to make sure we don't lose those two.
So Doctor, I couldn't hear you. Can you repeat that again?
Yes, sorry, just to make sure that we continue to learn about the status of permanent telehealth, if what's the status of it, and also the what was brought up in February and what was brought up this time about the recoups happening months and years after for providers. Well, we just talked.
So you're asking a department to do what now around the recoups?
No, I just want to make sure that we don't lose, that we don't forget that an update on the recoups, if the recoups are gonna be stopped. Or I just want to make sure that this topic of the recoups to providers months after the patient is seen, we don't forget about it.
We had a public comment on that, as well as Dr. Javier, and I've already asked our team for a meeting to get together to further that issue. So.
Thank you.
Okay, thank you, Director. Anything else from the committee in terms of recommendations or things you'd like to hear about in the next meeting?
This is Samir Vora. Just any kind of increased clarification on the integrated health home measures, especially the non-traditional ones that Kelly had been mentioning, I think would be very valuable.
Thank you. Howard Peters?
Yes.
Did you have a comment?
No, I was commenting on something that's already passed now. Thank you.
Okay, thank you, sir.
Dr.
Any
Whitaker,
other
one,
committee members with a recommendation or something they want to hear about on their next meeting?
yes, one other thing. The governor has been public about potential budget cuts if federal dollars don't come through. So we would definitely know what is want to know what the department's plans are if that money is not given to states from the federal government.
Thank you. Thank you. This is a pretty robust list. Do we need to, am I hearing from anyone else? Okay. All right. Well, look, I want to thank you guys. Thank the department for this very, very robust update. And then to the advisory committee for all their feedback. Let's move to new business and announcements. Is there any new business? And are there any announcements from any of the advisory board members? Hearing none. Old business? Okay.
May I address a question that was just asked?
Yes, ma'am. Yes, Director.
Marvin, the value-based purchasing report is on our website dated January 2020. I just found it. I thought it was out there, but I wanted to make sure first.
On your website, you know, your website is very difficult to navigate. Can you
because there's so much information out there, but yes, it's under there's a reports section and it's about halfway down.
Okay, got it. Thanks, Director.
Okay, so yeah, so Marvin, take a look at that and you know, let me know if there's any other follow-up that you would like, okay?
Okay.
I want to thank the committee for your level of engagement. I mean, you guys are, you know, bringing all your expertise to the table here, and I know I'm going to assume it's really appreciated by the department, an orderly way to hear from the public. You all represent many different parts of the Medicaid puzzle, if you will, providers from and consumer input, folks from across the spectrum of services provided by the department. So I want to thank you for that, you know, and I appreciate all of you reaching out to me ahead of time to tell me what you thought should be on the agenda. I think the department did a really great job of responding to pretty much everything that we sent in. So very, very, very robust meeting. If there are no further comments, I would entertain a motion to adjourn.
For adjournment, Madam Chairman.
For second.
Second.
For second. This is Kai.
All right. All in favor?
Aye.
We are adjourned, and I thank you very much. Have a great afternoon.
Thank you, Madam Chair.
Thank you.